Welcome back, everyone. I hope you had a great break. It is my great pleasure to introduce to you our keynote speaker today. Dr. Lynn Rapsilber she's a passionate speaker about cultivating the business brain of the nurse practitioner. Recognizing this deficit in NP education, she started NP Business Consultants, LLC, disseminating information regarding reimbursement for NPs, and is a recognized expert in coding and documentation. She is co-founder and CEO of the National Nurse Practitioner Entrepreneur Network, elevating the nursing model to transform healthcare delivery systems by creating a financially viable community of nurse practitioner entrepreneurs, one practice at a time. Dr. Rapsilber received her diploma in nursing in '81 from St. Mary's. University of Connecticut received her BSN in 1991, MSN in Adult NP in 1998. She attained her DNP in Nursing Leadership from Quinnipiac University in 2016. Dr. Rapsilber was honored as the Transformational Nurse Leader Alumni Award in 2017. She serves as the chair of the Connecticut Coalition of Advanced Practice Nurses, attaining full practicing authority for APRNs in 2014. She is the former Connecticut State Representative and serves as the Health Policy Chair for the American Association of Nurse Practitioners and a fellow. She was selected as the 2021 recipient of the Nightingale Award and the American Association of Nurse Practitioners NP Advocate Award. She currently owns NP Wellness Care, LLC, providing hepatitis C treatments at residential addiction treatment centers. Please join me in welcoming her for this session. She requests that you can send me as the moderator her questions, and we can stop her during the middle and she can answer for you. She's also going to ask some questions for you to respond to during this presentation, which you can send me. Thank you so much and welcome, Dr. Rapsilber.
Oh, thank you so much. I'm so excited to be here. It is a pleasure always to speak to NPACE, and I think that the rich dialogue that comes from the discussions that we have are going to be thought-provoking today. I'm hoping to maybe spark some entrepreneur spirit, but also to raise awareness about what's going on. As nurse practitioners, we are a hot commodity. And right now, it seems like every time you turn around, there's somebody who wants to help you start a business, or they're going to help you doing X, Y, and Z. So I'm hoping to give you some pearls and insight also as to some of the things to look out for as you're trying to make some decisions along your nurse practitioner journey. But one of the things that I'm passionate about is making sure that the nursing model of care delivery is preserved. And a lot of our NP entrepreneurs really want to deliver that kind of care. And we'll talk a little bit more about why that's so important. There we go. So our objectives for today are we're going to identify the challenges as these nurse practitioners were becoming this hot commodity. We'll look at some of the challenges and opportunities that this presents to us in healthcare. And we'll look at ways to become visible for nurse practitioners, because there's a lot of invisibility. And I think we need to do a better job of being out there in our organizations, in the communities that we serve, and in our own practices. And we'll look at also some of the ways that we need to protect our practice as well. This is my disclosure slide, and I think Lisa did a great job going over that, so I won't review that any longer. But I did want to pose a first question to you. What are the challenges that you see in healthcare today? So if you can type your answers in the chat and Lisa can share that with us, I would love to know what you, the audience, see as some of the challenges. And I'll just talk about the elephant in the room. COVID actually changed everything. I think when COVID hit, that created a door and opening to opportunities for nurse practitioners, and open for the barriers to be reduced for our practice. And so the challenge now, I think, for that is how do we keep those practice barriers reduced now that the pandemic is over and the public health emergency is stopped, and how do we prevent going backwards in our states? The other challenge in healthcare that we see is we have an aging population. And we know that many of us are going to take Medicare and be on a Medicare Advantage plan. And who's going to take care of us as we age? We see a lot of primary care physicians, the shortage of primary care physicians. So who's going to take that lead and take care of those population of patients? And really the onus is falling on us to do that. Don't be shy out there. I know you guys have great ideas. How about the explosion of chronic diseases? We're finding a lot of people now, even at younger ages, are having heart disease, diabetes, high cholesterol, obesity, and those seem to be becoming more and more prevalent and worse over time. And it's alarming because now we're going to have a population of people that are going to need significant amount of care down the road because they're not taking care of themselves when they're younger. So the preventative care aspect needs to change as well. We need to focus more on keeping people well, at their optimum level of wellness, out of the hospital, out of the urgent care, out of the ERs, where care is so expensive.
We have a few answers. We have poor healthcare literacy, multiple charting, low-income areas, access to primary care cost of medications, patients struggling with many concerns that we cannot adequately fix for them, but that affects their care, as in immigration status, effects of racism, housing, etc. That one's awesome.
I love that.
More complex patients, insurance barriers, more dispelling of healthcare myths due to social media web. Oh gosh, that's so true.
Disinformation highway.
Yeah.
Yeah. And how about corporate mergers and takeovers? I mean, how many have lived through the opportunity when a practice is being, incorporated into a larger healthcare system and the pain that brings along with it? And then really, does it actually make healthcare better when these entities are becoming larger and larger? Chances are not, because when you think about it, a lot of these corporations are now being run by venture capitalists. And who are they beholden to? Shareholders, not the patients, not the providers, even not the healthcare organization. We also have healthcare deserts. There are so many areas in each state where there's lack of care. And we're seeing that now even more since the overturning of Roe v. Wade. We know that there's a lot of OBGYNs and providers who are actually exiting some of these states because they don't want to be subjected to legal ramifications of just trying to provide healthcare, basic healthcare. So that's a challenge in and of itself. And our supply, that's the other thing. Our supply is going up. The number of nurse practitioners is increasing exponentially. So I think that also provides us with opportunities as well. So any other comments in the chat, Lisa? Those were awesome.
Not right now, no.
All right. So now
wait.
Oh,
here's one. Staffing and insurance reimbursement making profits.
Yes. And recognizing that nurse practitioners are providing high quality care and being recognized for that. So good point. So how are NPs going to change healthcare? So let's see, we know what the challenges are, but what can we do as NPs to change healthcare? One thing that I know I hear a lot from the folks that come to my sessions, and we interview nurse practitioners through the NP National Nurse Practitioner Entrepreneur Network who are inquiring about starting practices, is that they're frustrated with the medical model of care. The 15-minute visits, it doesn't really mesh with our brains and how we think. So a lot of folks are trying to figure out ways where they can provide care in a format that's more beneficial to the nurse practitioner and how they want to take care of that patient. How about advocacy? We need to have our voices heard. For many, many years, we have kind of done our work in silence and, just kind of let things cruise along. But we're really recognizing now that our voices really matter, and we do have to have a stake in healthcare. We do have to be able to articulate our message about who we are and what we do as nurse practitioners. I had the pleasure of going to Philadelphia a couple of weeks ago and presented the American Association of Professional Coders. Just for ha-has, I saw a thing looking for abstracts, and I said, oh, I'll just submit one and see what happens. And they selected my topic, which was documentation and coding from a clinician's viewpoint. And what gave me an opportunity really to meet the coders, which, by the way, you should know who the coders are in your practices because they're amazing and they can help you a lot with, making sure you're coding things correctly. But I also had an opportunity to talk to them about a nurse practitioner, who we are, what we do, how the nursing model of care differs from the medical model. We talked a lot about incident to billing and the struggles that we have with identifying it and then trying to rectify within our practices to make us visible in the healthcare space. And by the way, sold out.
We have a few responses for you.
Sure.
Roseanne said there's increased opportunities to provide care in the home as opposed to an outpatient clinic. We have access to care, detailed patient education on preventative care. We also have educating patients and colleagues, including physicians, about how exactly NPs provide care.
Amen to that. That's a great one. And the other thing that's important too is that the costs of care are rising exponentially. So in the United States, we spend about $12,500 per person per year on healthcare. The next closest countries are Germany and Switzerland, which are just a little over 8,000. That's a huge gap. Where is all that money going? And obviously our outcomes are not producing the patients that are healthier. I think we're a sicker nation, and part of it is the fragmentation of care that's going on as well. So that presents, a challenge for us. I love the comment about going into the patient's homes. I think one of the things that makes NPs poised to change healthcare is that we're going to look at it from the community perspective. What are the needs in our communities and how we as nurse practitioners can take that opportunity and problem solve. I mean, we're great at doing that. We just need to be able to have the tools and the expertise to be successful. But going to patients' homes, going to schools and daycares, going to long-term care, assisted living, for example, that's low overhead for starting up a practice. The biggest other area that's we see a lot of NPs interested in is transitional care visits. So when that patient's discharged from the hospital, it could be a great practice. You can see patients within that 7 to 14 day block, and you can keep these patients out of the hospital because you're anticipating problems that could arise and intercepting those sooner because our focus is really prevention. So the transitional care visits are another really great way to start a practice. Any other thoughts out there? We good, Lisa?
Yes, ma'am. We're good so far. It's going great.
All right. So our secret sauce, why will we be successful in the healthcare landscape? And I think you probably already know the answer to that, but I'll give you some clues. So we focus on the patient and the family. The emphasis is on function before cure. We focus on an engagement, not a transaction. So what does that sound like to you? Our secret sauce is the nursing model. So really what differentiates us from other clinicians is the way that we approach our patients and how we're trained. We're trained in that holistic approach to healthcare, looking at that patient, not just by their disease, but how they're responding to that. We also look at that patient for clues on how we can prevent disease from happening, that primary prevention, because we want to try to keep them at their optimum level of wellness. And all that equates with lowering the cost of healthcare, right? So what are some of the challenges to preserving the nursing model? Well, we need to understand the financial impact of nurses, and we need to understand our value and our worth. And we don't really get that education. We don't get it in undergrad. We don't get it in our advanced degrees, and we don't get it at the doctorate level even. So we really have a hard time trying to articulate what we're doing with patients and how we're taking care of them. So understanding our financial impact becomes very, very important. I'll talk a little bit about some of the opportunities that are out there. We also have to talk about amplifying our message about the nursing model because, like I say, we do a fantastic job of taking care of our patients, but we do a poor job of taking care of our profession because we're really not out there getting them of opinion to the table to get a seat at the table. And if there is no seat at the table, bring a chair and put one there. And we need to transform healthcare delivery by creating financially viable practices. I mean, we all know 85% is not going to pay the bills. So, and that's something that an act of Congress needs to change. But we do know that Medicare and Medicaid are the populations that we can best serve, and we need to serve them because nobody else is doing this. But how can we still have a practice seeing Medicare, Medicaid that is financially viable? And a lot of it involves niche practices that are add-on services that we can provide to our patients to get that revenue. And getting involved. You should belong to your state organization because everything that happens in your state regarding your practice is at the state level. And then federal, you should belong to AANP, for example, because they're the ones that are involved in federal legislation. And then the third one is a specialty organization. So if you're a part of, say, gastroenterology, you may want to join ACG or one of those organizations so that you're staying on top of the latest health information. So I want to talk a little bit about the financial impact because nurses and NPs, we're revenue generators, or are we cost centers? What do you think?
I have one response from a member that says NPs are expected by corporate companies to be productive as MDs, but we receive a fraction of pay and resources. Many healthcare companies are changing from RNs and LPNs to MAs.
Yeah, that's very interesting and scary at the same time because I think as our stock is elevating, the American Medical Association is putting a lot of pressure on states to keep our scope of practice, that scope creep issue. They're focusing a lot of our education. There was this article, The Miseducation of Nurse Practitioners, that Bloomberg did. It's going to be in the first of a series of articles. It was very telling because it really talked a lot about these for-profit nurse practitioner schools, which, you know, if they're not producing high quality grads, we as an organization and profession should be holding their feet accountable. But on the other hand, they took it a step further and put all of our education into that. Oh, well, we're not, you know, trained adequately. And that's not true. And the articles that they cited were just working papers. There really is no research that the AMA has that says that we're, you know, not putting out good quality work. So, and then we don't really have the power within organizations to make changes. There are hospital bylaws that still require collaborative agreements. And I had a conversation with one of my colleagues recently that was kind of eye-opening. And she said she's been in this institution for probably 25, 30 years. And she's pushed back on the collaborative agreement when we got full practice authority in Connecticut. But she just said now there's a financial incentive that the physicians are getting to be a collaborator. So she's being forced to sign an agreement now so that physician can get compensated for that. And by the way, they don't really do anything. The return on investment is very low, if nothing at all. But I found that interesting because in an institutional setting, if they took that money they're paying for these collaborative arrangements, which are merely regulatory, nothing to do with patient care, and actually they could hire a lot more nurses, right, at the bedside to help provide better quality care. So I think articulating or being able to articulate that difference really, really makes a lot of sense. Any other comments out there, Lisa?
We have Stacy that feels like that we are definitely revenue generators.
Yes, we are. Yes, we are. And we have to understand how we generate revenue and how we can maximize what we do. In my next session, I'll give you a lot of pearls about that. The other thing that's happening, and I don't know if you're aware of this, but there's a groundswell of activity in the hospital system to take the nurses out of the room rate, the bedside nurses out of the room rate, and put them in a line item. And I think that's fantastic, because when they say they don't have enough beds in a hospital, what they're really saying is they don't have enough nurses to take care of the patients. And so when they say they, have to cut costs, who are they cutting? They're cutting nurses. So if we can take a nurse, bedside nurse, out of the room rate, give them their NPI, and start looking at and documenting the services they provide, that's going to add a lot more value, because people are actually going to see the work that we do. There was a study that said 28% of what RNs do on the floor can be done by somebody else, either an MA or some other person. And to me, that adds to the dissatisfaction that bedside NP or bedside nurses have, is that, how do we fix this and make this different? And the EHRs, they have a great way of documenting the data that NPs and nurses do, and nurses at the bedside. So there's an opportunity there where we can generate more discussion about that. And it's going to be interesting to see what happens. I don't think the hospitals really want us to be on a line item, because I think they're going to be surprised when they see, but they're also going to see the value we bring, which I think that in and of itself is going to be super helpful. So I'm not sure if you're aware, but there is a Commission for Nurse Reimbursement, and this is a organization that's really looking at nursing from a sustainability and stability perspective. It is not affiliated with any major players, not the government or anything like that. They're totally independent. And they come from a diverse group of individuals. So there's nursing leaders, there's healthcare executives, there's policy experts and economic experts on this commission. And I actually had a couple of conversations with them, because they were focusing more on the nurse at the bedside. But I said, we should focus on nurse reimbursement across the continuum, which includes APRN. So I've got a seat as a commissioner on this organization, so that I can bring my expertise and that voice to this organization as well. And what they're trying to do is look at how, 5 million nurses are in America today, and that's a powerful resource. And we need to be able to have a way to funnel that into actionable items, getting the data and then actionable items that will actually move the needle forward. So I'm excited to be part of that, and hopefully I can get some information to you about that as we move along. So one of the things that is exciting is that we know that care has changed, and from healthcare outcomes, really looking more at how we're providing support for patients as well as clinicians. So we had the triple aim, which was improve patient care outcomes and lower costs. And then in 2014, the quadruple aim added in clinician well-being, focusing on clinician burnout. And then in 2021 was the quintuple aim, which included health equity. And the overall arch of this is really to provide better health and improve the economic standing within our healthcare system. So nurse practitioners bring a lot to this experience, because we have studies that show we do provide high quality care. Our patient satisfaction scores are extremely high. So we do get good responses. We're in the prevention and getting patients to the optimum level of wellness. So we're really focused on that prevention and keeping the diseases at bay as best we can by educating our patients and getting them the care that is going to keep them in that state. We're population focused, so who better to look at all of the aspects of taking care of a patient than nurse practitioners? And the other thing is we go where the care is needed. So we're going to the areas where they're healthcare deserts. We're going to meet patients where they are, which I think helps a lot. One of my colleagues started a practice going to patients' homes, and it was interesting because think about it, when you have an elderly person in their home and they call their primary care because they're having burning when they urinate. And what's the response on the other end? Well, we can see in about 4 weeks or a month or 2 months. And the patient gets upset and they're like, but I need to be seen now. And then what's the next response? Well, go to the ER or the urgent care. The worst thing that you want is to have that patient, that elderly patient, go to the hospital or the ER, because what are they going to do 9 times out of 10? Prescribe a medication, which they probably don't need. So think about it. If the nurse practitioner could go into that home, do that assessment of the patient, and maybe find out that the patient hasn't been drinking enough fluids. And that's one of the reasons why, because you can do a urine dip right at the home and find out they don't have a UTI. So, and we know with elders, UTIs, they present with confusion anyway. So this is an easily solvable problem right at the patient level. And I think that's how we're going to show our value in lowering costs of care. So let's remember our numbers. There's over 385,000 of us practicing across the country. Many are prepared in primary care. We see Medicare and Medicaid patients. And then we conduct more than 1.06 billion visits a year. But let me tell you, that number is probably 3 billion because of incident to billing, which I have a conversation about that in a few slides from now. But this is a good infographic. This is what ANA put together. They update it every year or two, and they put in the most current information. And this is a good piece to bring to your legislators to have a discussion about nurse practitioners because it's all inclusive. All they really want sometimes is that one pager. And this is a really good one to bring to the table. This was a study done by the Commonwealth Fund in 2019. And what they asked was, what group do you have the most trust in to fix healthcare? Look who ranked on top, nurses. So they also expect us to tackle the cost of care as well. So that's the problem that we have right now is we don't really understand the total cost of care and how to calculate that. We're great at what we do as far as our clinical skills we bring to the table, but our financial brain, our business brain, we really need to cultivate that a little bit more. So let's talk a little bit about differentiation of care models, because this is where the change in healthcare is going to happen. It already is happening. The medical model, physicians take care of diseases. So the patient already has to be sick. And what this does is it focuses on what you do for patients more so than keeping them healthy and well. Where the nursing model, nurse practitioners take care of patients and people with diseases, or they try to keep them to their optimum level of wellness or prevent disease from happening because we know what the history might be in their family and we can intervene earlier to prevent those diseases from occurring. So when you're looking at healthcare, where do you want to invest your money? And we know the medical model doesn't work. So why do we keep throwing more money at it that's only increasing the healthcare costs across the board? We really need to focus more on the nursing model. So one of the things that we can challenge is, how about that GME money that the government puts towards general medical education to train new primary care physicians, which we know that's not happening, and divert those funds to nursing so that we can get more educators in the healthcare system. We can help create nurse practitioner-led practices in communities where the populations are underserved. So there's a lot of value that we can bring to the table if we're just given the opportunity and can articulate that message. And the evidence is there. We know compared to our physician colleagues, our quality is equal, if not sometimes better. And especially with patients that are at risk, we can take care of the toughest patient population and keep them to their optimum level of wellness, which is fantastic. And I'm sure you know that most of the times the patients that you see are going to be, or the physicians are going to cherry pick the patients that they want to see and give you the other folks to take care of. And we do a really good job. And we have to be aware of how to articulate that. Our costs are probably about equal because when you balance out what we can do under the nursing model to care for patients, to keep them well, it probably will balance out by the illness care that's delivered. But what we're going to do is prevent the higher utilization of more expensive services because we're keeping that patient healthy and well. And our utilization of services is probably about equal. And our capacity for complexity is probably equal and sometimes better overall. So the numbers are there. The evidence is there to really support what we bring to the table. So NPs are in a great position. Why? Well, I believe NP is the new paradigm. And we're the ones that are going to shift healthcare because we have to. It's not a question. It's happening now, and we have to be poised and positioned to be able to make that happen. So when we talk about the nursing model, we really need to be able to amplify our message. How do we get the word out? Our model is different, and we need to tie it to value. Like, what's the value we bring as nurse practitioners to the organization, to the patients, to the community? Know the audience that you're going in front of to deliver this message. And we can identify gaps in knowledge, skills, and resources to help us move forward as part of our interprofessional teams. We do bring value to the table. And sometimes the nurse practitioner should be the team leader, not necessarily the physician. So, and sometimes it might be a nutritionist. It depends on what the patient is, and it really should focus more on what is going to benefit that patient, not what's going to benefit the model overall, but how that patient is going to be best handled. And we have to articulate how advanced practice nursing is bridging the gaps in specialty care that we seek to render. We want to make sure that our care is evidence-based and that it's based on facts, because guess what? If we ever get called into court to defend our position and we don't have the evidence to back it, we're not going to be able to stand up in a court of law. So make sure that what you're doing is evidence-based. And we need to have our personal relationships with our patients, because guess what? That's what adds value to what we bring to the table, because we treat patients as individuals, not as their disease. So we're more likely to engage with them. We're more likely to, they're more likely to tell us more information, which we can help provide better care to that patient. And those relationships have value, and patients really, really enjoy that connectivity with their patients. And just think about it. It's a privilege to walk into somebody's home. For them to allow you to come into their home, that is a privilege. So I think that's the other thing that's undervalued in this whole model of care is the personal relationship that we bring to our patients. And we need to be visible. If you have opportunities to be in your community, go speak. Go to the senior center, deliver a talk on whatever topic you feel comfortable with. Go to the Chamber of Commerce. They often have different types of committees. They might have a health council or a health committee that you could actually start to attend and see how you can make impacts in the community that you serve. Go to daycares and give a presentation in a daycare. So there's a lot of ways to get our message out and to make us more visible in the community. So I just gave you a couple of ways to amplify our message, but do you have any ideas on how we can amplify our message out there of who we are and what we do? One thing that I did is there was a article that this journalist had put in, and it was a commentary, and it was about her experience at a physician appointment and how she basically was given a short window of time to see the person was very short in the interaction and was given a prescription, and off they went. And she just felt it was so impersonal, and her message was, what happened to healthcare? And so I wrote a response to her personally, and I said, because you didn't see a nurse practitioner. I said the care you would have gotten from a nurse practitioner would be different. And I cited some of the reasons why I felt that way. Well, she thought it was fantastic. And she said, you know what? You need to make this an op-ed piece and put it in the letters to the editor, which I did. And it did get a lot of response. And so that's one way that I was able to elevate and amplify our message just by having a conversation with someone.
I have a couple of comments. I have one comment that states, working at the bedside, especially during COVID, opened my eyes to how valuable nurses are. The only people that could go in a patient's room at the time was the nurse or physician. So guess who was taking out trash, delivering trays, cleaning patients, etc. We also have a response from Christina saying we could volunteer to amplify our message.
Yeah. Volunteering is great, but also we have to value our intellectual property as nurse practitioners also, because I think a lot of times we want to help, but then we don't value our intellectual property the way we should. So yes, volunteer, but if there's an opportunity, you should be paid for some of the things that you do. even if it's a small stipend, just to show that you have value. I think that that's something that we have to start feeling comfortable with, because it is kind of an uncomfortable area to be in. But we can't give away our intellectual property all the time, but it can give us some inroads as far as how we want to interact with our community, talking with legislators, for example, and things like that. Great comments. So again, we need to articulate our value. We do have a lot we bring to the table, and we do need to be able to interact with our communities, interact with our thought leaders in our institutions, get connected with think tank groups within your community and your specialty areas, for example, and see how we can articulate our value. But there are some threats to our NP visibility. One of the things is losing the nursing model in healthcare. And I think we really have to start articulating why the nursing model is so valuable and so important, because that holistic preventative care is really what's going to help transform healthcare delivery. And it may mean that we have to look at different ways to deliver that care, devoid of some of the insurance barriers that are in place. There's a couple of nurses who are working on communities and looking at the public utility model as a way to transform healthcare. So there's some pilot studies focusing on that. So we have a lot of great solutions we might be able to come up with to help bolster the nursing model in healthcare. There are a couple of things through CMMI, the Centers for Medicare and Medicaid Innovation, that are looking at different types of models of care delivery. And two of them are the REACH ACO, which is looking at high needs in the elderly population. And that is really good because it reduces all the barriers to practice, which is phenomenal. So we really will get a good comparison about how we take care of this high-risk population and how we are more cost-effective with the distribution of resources. The other one is the AHEAD, and this is Medicaid managed care. Right now, there's 4 states that are piloting this. It was launched in Maryland to start. Hawaii was the second, and then 2 other states were just added, Vermont and Connecticut. So we need to get seats at the table. I'm from Connecticut, so we're trying very hard to get seats at the table so that we can start looking at how those nurse practitioner practice owners in our state are taking care of these patients and can be part of this program so that our data can start to be looked at. Incident to billing, we'll talk a little bit about that shortly, but incident to billing is when the nurse practitioner delivers the care, but it's billed under the physician, and that comes with a lot of concerns. ACO attribution, we'll talk a little bit about that as well. We can see patients, but they can't be attributed to us. So what happens to the quality measures that we are given to these patients? You know, who gets credit for that? And then seats at the table, we'll talk a little bit more about that as well. So let's go to incident to billing. This is important. It's important every NP know about this type of billing because it can be problematic. And that's why I'm going to spend a little bit of time on this area. So what it means is that the rendering provider and the billing provider in the eye of the payer are the same. And so the rendering provider is the nurse practitioner. Ideally, we want it to be the same person. So if the nurse practitioner is rendering the services, they should bill under their own NPI number. What happens in incident to billing is the nurse practitioner is the rendering provider performing the service, but as the claim goes in, it's going to be listed under the billing provider, which will be the physician. And, you know, that is very attractive to a lot of practices because they get, 15% extra reimbursement. Instead of the 85% for the nurse practitioner, they get 100% reimbursement. So the lure of getting that extra 15% is real. And a lot of practices are looking to do this in light of trying to, gain better reimbursement and more financial revenue for their practice, but it comes at a cost. So one of the things that, if anything, take this slide and make sure you take a snapshot of it, because this is what you'll need to go back to your employers if you suspect that there's incident to billing happening. So we know our practice authority based on our state, what we're allowed to do. Under incident to billing, which by the way is only for Medicare. So what I'm telling you is for Medicare. you have to be under direct supervision by the physician. So this means that that physician or a physician needs to be in the office at the time the services are provided by you. And that's basically, they don't have to be in the exam room, or they don't have to do any repeat work with that patient, but they just need to be there in case you have a question, that you can go and talk with them and make sure that there is definitely availability of that supervising physician. The physician must be accessible, so they have to be in the office. They can't be on the golf course. They can't be on vacation. They can't be in an endoscopy suite, which is a door between the office, but it's a different tax ID number, so that doesn't count. And that physician must be, the nurse practitioner must be employed by the physician, so that group must sign their paycheck. And the physician must have the initial patient service. So every new Medicare patient must be seen by the physician so that they can develop the treatment plan. The physician also must have active participation in the care, so that when you're identified as the nurse practitioner who's going to see that patient for the next visit, say to monitor their blood pressure medication, if that patient is seen by you for the rest of the time that they're part of the practice, that doesn't fly, because the physician has to have active participation. So you're basically going to be shifting that patient back and forth between you and the physician. And they can't have a new problem. So say you're meeting all this criteria, everything's fine, and then you see the patient and they're like, oh, by the way, I have a seborrheic keratosis. Can you cryosurgery that for me, or can you freeze it for me? And you'll say, oh, well, if you do that, then you've changed the treatment plan. So it's no longer incident 2. It needs to be billed under your NPI. They can't have a new problem, because only the physician can change this. This is not just co-signing notes. That's the other thing. It's really important that you understand that the physician has to do some work here, and they have to get some credit for it. So, and it's very problematic, because I've heard stories over and over in my journeys about incident 2 billing, where NPs are left alone in the office, or the provider went to Europe for a month and they're stuck seeing the patients, and the providers were being billed under the physician even though they weren't there. So they had to go back and actually challenge. A couple of folks found out that it wasn't the physician that was the problem. It was the practice manager who was looking at the opportunity to get the extra 15% and was billing incident 2. So sometimes it's not your physician. Sometimes it's your practice managers who are looking at that additional revenue. But this is the slide you need to take back and go back to them and ask those questions.
I have just a couple of comments.
Mhm.
We have where you ask how to get a seat at the table. Christina advised joining a committee. And we have a nurse practitioner that stated that she spoke on a healthcare panel for college-age students. There was an NP, a PA, and an MD. They were very surprised how many students were not even aware that NPs existed.
Oh, interesting.
I know. There's another comment. Oregon State has pay parity. I hope that more states follow suit, as NPs provide high quality care and high value care. And that was from Shannon.
That's great. And again, I think this speaks to the opportunities that you have to be part of the political process in creating policy, not the political process for party's sake, but for policy's sake, because that's really where you have to be involved. And if these things are passionate for you, your state organizations oftentimes are the ones that are putting bills forth. In Connecticut, we have what's called the Coalition of Advanced Practice Nurses, and it's our NAPNAP, GAPNA, our Psych NPs, our Connecticut APRN Society, the Connecticut Nurses Association, independent practice owners. So we all come to the table and we talk about legislative issues. What are we going to support? What do we step away from? What other bills that we're going to be supportive of? Who's going to go and talk to our legislators? So because we have this coalition, we've come to consensus. So we're all approaching our legislators with one voice, one message. And I think that's huge, because one of the problems I hear oftentimes is that, each group is trying to message for their particular cause. And when they're hearing all this noise, they're thinking, wow, this group is not organized. So if you can try to work within your practice in your state for your practice authority at the state level, that's going to be huge. So I appreciate trying to get seats at the table. And pay parity, I wish it would be faster coming, but again, I think this Commission on Nurse Reimbursement may start to address that issue. So thanks for bringing that up. So what are some of the impacts of Incident to billing? Our NPs are invisible. So when you think about it, that claim's going in under the physician NPI, so that NP is not being seen by the payer. And the quality measures, guess what? You do a great job of keeping that hemoglobin A1C down. And that physician's going to get credit for that. And what happens is the bonus money goes to them, which is a whole nother area on value-based care and quality measures, which, I could do a separate talk on that. But you have to understand how that system is set up so that you take advantage of paid for the quality measures that you're keeping under for that practice to get the bonus money. We must meet all that criteria that I just had on that slide. There are unintended consequences, and it can be viewed as fraud sometimes. If you're not meeting this, the Office of Inspector General is really clamping down on incident to billing because they know it's fraught with fraud. And what happens is sometimes you can lose your ability to be a Medicare, Medicaid provider because when they come in and investigate, they'll investigate the whole practice from the top down. And if it was the practice manager that implemented this, or it was, and they implemented it and you knew it was going on, I mean, everybody's going to fall down with it. It's a trickle down. It used to be just the practice would be held accountable, but all of us are. And if you get sanctioned by Medicare and Medicaid, where you're excluded as a provider, you might as well hang up your shingle, your nurse practitioner career, because who's going to hire you? There's no private insurance company that's going to give you any credentialing because you've been under investigation by Medicaid, or Medicare or Medicaid. So think long and hard about the impact of incident to billing and finding out. So the first thing I would say is go back to your practices and ask how they're billing for your services. And if it's incident to, show them why it's important. If you're not meeting that criteria, show them that slide. The other way to articulate value is through the relative value unit. So this has become very important because billing and reimbursement is tied to geographic practice cost indice, RVU, which is work, and a conversion factor. And then the CPT has actually 3 parts: a provider work, a practice expense, and a malpractice expense. And that is translated into this lovely formula on how we get paid for our services. So there's a work relative value unit times a work geographic practice cost indice. And the geographic practice cost indice reflects for the cost to deliver care based on where you live. So in New York, for example, and California, it's more expensive to deliver care than it is in Alabama, for example. And then that's added to the practice expense RVU, the heat, lights, utilities, and the practice expense geographic practice cost indice, plus the malpractice RVU times the malpractice geographic practice cost indice times the conversion factor. That's the one that you hear Congress trying to set that rate every year. And there's a lot of argument about whether it should go. Everybody wants it to go up, and sometimes it'll go down, and then there's infighting, and then they try to solve it. But it's a sustainable growth factor. And unfortunately, it has to be budget neutral. So if they take from specialty care and put it in primary care, I mean, it has to balance out. So somebody's going to lose something. And then it's times the practitioner payment rate, which is 85%, but it can be lower in the Medicaid programs. Some of the behavioral health clinicians were getting 65%. So we know that we have some work to do. So again, go in with open questions. How you're billing for my services? How is your productivity measured? So that you can start to determine your value. We need to understand our impact at work. So we need to know our financial contribution to the organizations. I love, being part of committees, being part of the decision-making process, asking the questions, and knowing how you're contributing to your organization. Looking at improving your outcomes and your visibility. How can you help be a solution to some problems you might see? And this way, your value will start to be recognized and your voice will be amplified. So I really encourage all of you to start thinking about ways in your organizations how you can have that impact felt. And we're switching over to reimbursement a little bit because we know the healthcare landscape is changing. Fee for service really is more incentivized by volume, which the medical model has been incentivized by volume for decades. And we know what happens with that. The costs of care keep going up. So now the shift is over to value-based payment, where we're looking at high quality care that's cost effective, that has high value. And all of that really points to nursing and the nursing model of care. ACO attribution. So a lot of organizations now have accountable care organizations where quality measures are being attributed, and it's a risk-based model. So some of these ACOs have little risk, MIPS, for example, and some have more risks, which are your advanced payment models. So your larger institutions are going to have more reward because they're sheltering more risk to take care of patients. Can you see the patients in the ACOs? And in the ACO, does the care need to be attributed to the physician? Right now, yes. Medicare Shared Savings is giving us an opportunity, and legislatively, we need to get that changed. The REACH ACOs are really giving us hope because we're the ones that are providing that care to the elderly. So we get an opportunity to be part of that. We're the ones that are seeing the patients, especially independent practice owners that are part of ACOs. How is your care going to get credited when a physician has to have the attribution? So these are questions you have to know, that you have to ask these questions before you engage in a relationship with an ACO, for example, and who gets credit. And we need to educate ourselves. So we need to understand about these models of care and how we fit into them. So what I'm stressing is start to ask a lot of questions, lots of questions, looking at the opportunities that are out there to participate in some of these programs and educate yourself. More and more is coming to the forefront about value-based care and how the nursing model fits very nicely into it. But we need to be able to understand it and be able to communicate that to folks that need that education, like our legislators. So where did you learn about business? Practice ownership is an option that's available. And the good news is quality and utilization outcomes are stellar. Our practice owners are giving phenomenal care and keeping costs down. The bad news is that our outcomes are not sustainable unless we understand how to do business and how to understand reimbursement. And guess what? How many of you had education in your programs? Probably none of you. So the good news is we can teach you that skill. That's not something that is fraught with misunderstanding. It's a concrete program that is easy to understand, and that NPs are not born as entrepreneurs, but they can be made into entrepreneurs as long as you have the determination and skill set that you want to do this. So why do NPs want to be entrepreneurs? Because we want to give the care that our brains are hardwired to give. So, and that's not a 15-minute visit. We need at least a half an hour, even an hour with our patients. So the good news is the way the reimbursement structure has changed, we can decide medical decision-making or time. So it gives us the opportunity to look at time, valuing our visits a little bit more with forethought and how we're giving care to our patients. So I often hear is what's preventing me from starting a practice? Well, fear of, failure, fear of making a mistake, not having the knowledge and knowing where to go to find it. There are a lot of people out there now. You may even be solicited by a lot of folks who say, hey, I want to help start a business. I'll give you all the tools. You just go see your patients. And the problem is if we don't understand the business skill set and what's involved, we could be taken advantage of. So we do have to have some level of knowledge about a practice before we can jump in. And oftentimes we have a hard time finding money to start up. So a lot of folks are doing going to patients' homes or doing telehealth as a way to start a business, or doing cash pay. Will not be sustainable. How am I going to be able to survive if I take Medicare, Medicaid? A lot of times people are doing this in isolation and hoping that they don't make significant financial or business mistakes. But so all of the above are things that could be preventing people from starting practices. So what are some of the tools we need for practice ownership? And I know we're getting a little low on time here, but some of the characteristics you need to possess is you have to have a willingness to learn new skills. You have to be somewhat thick-skinned, because starting a practice is not for the faint of heart. We need to have a good understanding about business, what it means to have a profit and loss sheet. How do you view your startup expenses? How do you go to a bank and get money? How do you start and develop your business plan? So these are just some of the things that you have to have a better understanding when you want to start a practice. So please, take some time and do your due diligence. If you're partnering with people or you're inquiring with folks that want to help you, here's some words of wisdom. What do you know about a nurse practitioner? Do you understand the nursing model? Do you employ an NP? Do you have them at least on your advisory board? Or do you consult with them? If the answer to any of those is no, they're not for you, because a lot of times these companies are wanting to create mini medical practices, but stick an NP at the helm. And that's not what we're looking for. We're looking for a total shift in the delivery of care that we want to give. So please keep that in mind as you move forward. The other thing to think about too is there's a lot of specialty areas that are coming along. And what Barbara Safried did, she did a really good job of her can, may, and should. Can you do it by your education and training? May you do it by your practice authority? And should you do it for ethical and legal issues? Is there evidence to support that? So when you're thinking about doing something, keep those three words in your mind: can, may, and should. These are some of the specialty areas that folks are getting involved in: injections, infusions, some procedures, lesion destructions. If you're doing any of these, make sure that you're going to understand your malpractice is going to be impacted. You will, as you're doing these procedures, they're higher risk, so you'll be paying more in malpractice. You have to be credentialed to do them, and you have to be able to code them properly. A lot of times it's modifiers and documentation. And think about your training for this. A weekend class to learn Botox is probably not the best. What you really want is a company that's going to train you properly and make sure that you're the right person to do this, because a lot of times these are cash pay entities, which will generate a lot of revenue, but they do have some risk associated with them as well. And you want to make sure that they're evidence-based. So when I'm talking about some of these niche practices, what are we looking at? Weight management, that seems to be one of the hotbeds right now. Everybody wants to, get the Wegovy, the ZenPep, or the ZenBound, and Mounjaro, and all of those. But the problem is that's a medication that addresses one aspect, when it really, weight management and obesity management is the root cause is the obesity, like what behaviors are impacting this. So it really needs to be a comprehensive approach to weight management. Wound care, aesthetics, all of these are great business opportunities, but they come also with making sure you're getting properly trained to do them. Other business opportunities, you could speak for at different organizations. You can become a speaker. If you have a specific disease focus, you can go to conferences and start speaking and generate some revenue that way. You can become a pharma or a medical device expert and help in that way as well. You can become a participant on an advisory board. You can do legal reviews. That's a very popular area to get involved in. Or you can, if you're great at writing, you can write something or author pieces. You could do CV reviews and things like that. So there's a lot of other ways to incorporate business into your practice as well, other than patient care. But be mindful, you want to make sure that they're evidence-based. It's not all about the money, honey. One of the things that I want to focus on too is that, just making sure that when you're partnering with folks, that you think about the link. So we love our NPs, or I love my NPs is great, but that's kind of a little pat on the shoulder, but you have to start asking a lot of questions. Like I said, what do you know about NPs? What do you know about the nursing model? Do you employ an NP? Do you consult with NPs? Are they on your advisory board? If not, run. The other thing that's important is know what you're signing. So read these contracts well, even your employment agreement. The promises and the realities are often different, and how you're going to get out of this if it doesn't work well, because oftentimes it's like the honeymoon, everything's great, and then guess what? The marriage doesn't work out, and how you get yourself out. So you have to protect yourself. And getting involved. Getting seats at the table, being part of your state organizations are so important. Be able to speak with one voice, meet with your legislators, and share your stories. All those are ways that we can promote the nurse practitioner role and get involved, because we are a hot commodity. So these are some of my references for some of the articles that we spoke about, and I will allow some more time for questions if anybody has any. But thank you for letting me be part of this discussion today.
That was absolutely awesome. We have about a 15-minute break coming up in a couple of minutes, and we will be doing some yoga. If you guys are interested, please make sure you do the post test. We had one question really quickly discussing the difference between inpatient hospital billing. I'm not sure if you'll have time to get to that. Because you had discussed incident to billing, they were asking about inpatient hospital billing.
So inpatient hospital billing is often DRG related. So your documentation becomes pivotal in the inpatient setting. How you document it becomes important. The other thing is if you are an outpatient in an office setting and going into the hospital to see patients and doing split shared, that's a whole separate model of billing. And that's being scrutinized now too, because what they found is nurse practitioners or PAs are doing the lion's share of the work. The physician might come in and just co-sign the note and they're billing under the physician. Well, that's been recognized as not what's really happening in reality. And what Medicare did is they shifted whoever does the lion's share of the work owns that. So that's where that comes in.
Awesome. Thank you so much. Okay, everybody, we have a 15-minute break. Stretch those bodies, enjoy some yoga, come back at 11:15, and we will be back with Lynn about coding updates and pearls. Thank you. Thank you, Lynn. That was awesome.
Thank you.